My name is Gina Febraro, and I'm the Maternal and Child Health Manager at the Colorado Department of Public Health and Environment. As many of you may know, the maternal and child health is defined as the professional and academic field that focuses on the determinants, mechanisms, and systems that promote and maintain the health, safety, well-being, and appropriate development of children and families and communities and societies, really in order to enhance the future health and welfare of the next generation. And what's critically important within this definition is two factors. One is that maternal and child health refers to a professional field, and it's also an academic field. So in many schools of public health, as you may or may not know, there are actually departments dedicated to studying maternal and child health issues. And the professional side of the field, of course, is all of the practitioners who are on the phone today. And it's a really nice partnership between the two sides of theory and practice. Secondly, that since the early 1900s, maternal and child health has been dedicated and committed to promoting and maintaining the health, safety, well-being of children, adolescents, and women of reproductive age. And that mission has remained true and consistent throughout time. And it's one to be proud of course. So maternal and child health is obviously a very, very broad field. I took this topic index from a national website that serves as a resource for maternal and child health professionals, and it's really just an example of the many, many different areas that maternal and child health professionals work to impact on a daily basis. And one of the challenges, obviously, is that there are limited funds supporting maternal and child health services, and yet there are many, many issues to be impacted, and so therefore there's prioritization that's needed and decision making in order to choose what are the most important issues, and also how can we best use our funds to basically make the biggest bang for our buck. Over the years, some of the landmark projects in maternal and child health have included nutrition during pregnancy, lactation, standards for prenatal care, strategies to prevent childhood injury, and safety standards in child care. And these are just to name a few. The maternal and child health system is complex, and it exists at the federal, national, the state, and the local levels. And one of these components couldn't exist without the others, and I think that's critically important to recognize as well. We're going to take time in today's presentation to review each one in more depth. So beginning with the federal and national level, our partners are also obviously essential to us achieving our work here at the state and local level. And the Maternal and Child Health Bureau is responsible for providing leadership around maternal and child health issues at the national level. One of their primary functions is to administer Title V block grant funding, and as well as providing technical assistance and support to the states who receive the block grant funding. I have the opportunity here to click on websites so you can see, for those of you who may be newer to the field, that you can access their website and look for different resources, funding opportunities, etc. Secondly, there's the Association of Maternal and Child Health Programs, or AMCHIP. And this is a membership organization that's housed in DC, and they provide professional development opportunities, technical support, resources to state maternal and child health programs, as well as to local maternal and child health programs and staff. They hold a professional conference every year in February or March that's very, very large and well attended and very well organized, as well as lobbying on the Hill for maternal and child health funding and support in DC. Finally, there's City Match, which is another membership organization that provides support to professionals in the MCH field, and they focus on urban maternal and child health issues. Once again, they have a conference and resources and support that they provide. So I started in this field well, truly my whole career has been in this field, but just in the last couple of years I've been working more formally within the maternal and child health program here at the health department. And one of the exciting things to me as a newer professional in this field was to have resources at the national level that I could access and that would provide me with support. One handout I'd like to refer to at this point is it's called Quick Access Orientation Materials for New Title V Staff. And it's produced by the Maternal and Child Health Bureau, which I'm not sure if I mentioned is housed at the Health Resources and Services Administration at the Department of Health and Human Services. But this is an excellent resource to provide newer staff with some history, vision, mission around Maternal and Child Health Bureau. There's also access here to a timeline of the maternal and child health field, as well as at the very bottom, well, leadership competencies, and then at the very bottom, Maternal and Child Health Leadership Skills Development Series. This was actually developed at Johns Hopkins School of Public Health. For those of you who may not have accessed it yet or who may not have or are not familiar with it, there's 6 modules and they're interactive, there's video, there's little exercise or participatory exercises. Some groups within the health department here have done this as a group, and I found it to be very well done and very helpful. So I just wanted to make you aware of that resource, and it's free, which is even more important. So if you would like to learn more about the mission and the Maternal and Child Health Bureau, I'll refer you back to that handout and to some of the resources that they've produced. At this point, I'd like to move on and talk a little bit about Title V, which is known as the Maternal and Child Health Block Grant. The history of Title V actually dates back to the late 1800s. And without spending too much time on it, one primary milestone that is worth mentioning is that the Federal Children's Bureau was created in 1912 to investigate and report on the status of children and on their common as well as special needs. And this bureau was successful in creating uniform birth registration, the school lunch program, child labor laws, and maternal health standards. So this was really a precursor to Title V funding back all the way in 1912. In 1921, an act was passed called the Shepherd-Towner Maternity and Infancy Act. And this actually provided the first federal grants to states for public health. The act was controversial for the government having an activist role in health, and it was actually viewed as radical and socialistic, which I find comical. At any rate, the law fostered the creation of child health units in 47 states, many of which remain today. So when the Social Security Act of 1935 was created, they really used these two first, oh sorry, how did that happen? Sorry, we just realized that you are not looking at the PowerPoint. And so Sarah is remedying that. Sorry about that. So when Social Security Act was created in 1935, they used these prior to acts as a jumping off point and really extended the Shepherd-Towner Maternity and Infancy Act and continued to provide grants to states to support services for children and adolescents and women as well. And just to put it into context, the Centers for Disease Control, which is really our public health agency within the United States, as you know, was created in 1946. So the Title V block grant the Title V funding has been around for a very long time, and as a result, it's a very important part of not only our day-to-day operations, but also our history. So a couple other small fun facts about Title V. It's the only federal program devoted to improving the health of all women, children, and families. It serves 33 million women and children in the United States, and 80% of all American children and adolescents are served by one or more maternal and child health programs. $662 million goes out the door to states in formula funding, and then they also have other competitive grant opportunities of which not only states are eligible for, but also local communities, which are listed there. And as you saw may have noticed on the MCH Bureau website, if you're ever interested, the grant opportunities are listed on that site. So some important tools and frameworks to mention that are available from the federal and national level, and this is where I've talked a little bit earlier about this presentation providing the picture around strategy and direction for maternal and child health programming. A lot of that does come from the national level. The first piece, I'm going to pull up the handout again, is called the Maternal and Child Health Performance Measures. And as you can see here, there are 18 national performance measures, 6 maternal and child health national outcome measures, and then the Colorado state performance measures are listed on here as well. These performance measures were created in response to the Government Performance and Results Act of 1993, which required federal agencies to evaluate their services and demonstrate effectiveness. The performance measures were created as well as soon after the pyramid, which I'll speak more about. Colorado is responsible for addressing all of the national performance measures at the state level, and we do this oftentimes in a monitoring capacity. So although we may not have programs around each of these performance measures, we do at minimum monitor them to ensure that there are no drastic changes from year to year that we need to address. The next, okay, so I'm going to close this. And it still didn't come back up. So I have to go back up to it. Sorry, everyone. Okay. So the next tool that was produced at the federal level, and this really, when, maternal and child health for a long time was solely focused on providing direct services, clinical services. And, over time there's been a shift to a more population-based services and serving in a public health capacity. And in order to help agencies define what those services would be, the Maternal and Child Health Bureau and AMCHIP put together the 10 essential actually this was put together, I believe, at Johns Hopkins, but put together the 10 essential services to promote maternal and child health in America. And these are very similar to the 10 essential services of public health. They basically include our target population in each one to make them more specific. But what this really does is provide a blueprint for public health agency operations and a framework to help us define really our function within public health. Finally, and we weren't able to open our pyramid handout on our computer for some reason, but you have access to your handout of the infamous pyramid for your reference. But I am going to spend a little bit of time talking about the purpose of this tool. And essentially, in doing some research on where this tool originated, it was designed as a program planning tool for programs and program staff to determine what the best way to target an issue is, or what the best target of intervention or strategy is in terms of impacting outcomes on a certain health issue. And what the pyramid really says is that, and public health theory supports, is that really one of the best ways to target a health issue is to approach it from multiple levels. So just to go through the levels quickly, because we do refer to this pyramid a lot in referencing our strategic direction. Direct healthcare services at the top, and this is really the gap-filling function of maternal and child health, and it's providing those one-on-one direct services such as immunizations or specialty clinics with children's special healthcare needs. The next level down is enabling, and this is really for groups of individuals who share defining characteristics. So, for example, a group of pregnant women or a group of smoking people or a group of adolescents who are, substance abusers or whatever the case may be, or users. But some of the types of program strategies would be health education, smoking cessation, and case management programs. Then as you move further down the pyramid, there's population-based strategies and approaches, and these really are services delivered to the entire population. So whether that population is in a workplace and there's a workplace safety program, or whether it's the population in a county or a state. So there could be a screening program such as a newborn hearing screening or fluoride or social marketing campaign. And finally, there's the infrastructure level at the bottom of the pyramid. And these are approaches that help support all of the other kinds of programs that you might do, and really help support, everything from agency operations to public health functions. So, needs assessment, evaluation, planning, policy development, quality assurance, standards development, etc. So some examples would be, this training, for example, and increasing capacity of staff, creating clinical guidelines, doing your needs assessment perhaps with your local planning process, etc. Another key point about the pyramid is that the reason we use it to represent our strategic direction is because we are responsible for serving the entire MCH population in the country as well as in the state of Colorado. In order to do that most efficiently with the limited dollars that we receive, it makes more sense to do services at the lower levels of the pyramid versus at the top of the pyramid. One-on-one services are obviously a lot more expensive and impact a lot fewer people, whereas population-based services and infrastructure level services can impact an entire population, and basically we can see more outcomes, hopefully with effective programming, to impact more of the MCH population with the limited funds that we have. So moving on, finally, as I said before, the public health approach is one that we've adopted more and more within the maternal and child health field. And this is just another illustration of that approach, whereas program staff would identify and define what the issues or problems are, identify causes where, today we use language such as identifying contributing factors or social determinants of health and understanding why a problem exists. Finally, instead of potentially developing and testing interventions, which some of you may do at the local level and we may do at the state, there's also the opportunity nowadays to identify and select interventions that are already evidence-based and already exist, implement the interventions, and then evaluating them. And this is really cyclical, and it really never ends. You're always in one phase or another in addressing health issues among your population. So moving on to Colorado maternal and child health. One thing I'd like to show you at this point is the website that we have, because it is kind of Colorado's clearinghouse for maternal and child health information. Move this window away from the shared application. I'm getting a message. At any rate, on the home page you can see our vision and our mission. Our mission is to optimize the health and well-being of maternal and child health population by employing primary prevention and early intervention public health strategies. And then if you would like to link to any of the different unit programs that are involved with maternal and child health at the state level, you can link to those here. There's also the block grant application that we have to submit to the federal agency, to the Maternal and Child Health Bureau, is listed here, as well as an overview of our needs assessment, which I'll touch on in a few more slides. There's also some data resources here that I'd like to point out. For one, there's the health status report, which is a report on basically the quantitative data overviewing the MCH population in Colorado that was just produced. If you go over to Colorado MCH data. Oh, you're not seeing it. Sorry, everyone. This is part of the technology issues. That's okay. I'll just say that there's county data sets on here as well, and if you could see it, that would be really cool, because I wanted to show you where they were. But we will just move on. So We already talked about our mission. In terms of staff within maternal and child health, we fund a lot of state-level staff in the different units that I just mentioned. But we also have the director, who is, of course, Karen Truweiler. Many of you know her. Program manager and myself. We have a health planner who helps prepare the block grant, oversee another data initiatives grant we have with Sarah Wargo, who's our program assistant. We now have 2 MCH generalist consultants, as one of ours just retired, Lynn Bindle, but Kathy White and Julie Davis are the MCH generalist consultants who work with local agencies around planning. And 3 of the core funded units within the Colorado Department of Public Health is the Child and Adolescent School Health Unit, the Women's Health Unit, and the Children with Special Health Care Needs Unit. And a new event that's occurring here within the division and center is that the Children and Adolescent School Health Unit and the Children with Special Health Care Needs Unit are merging and integrating into a branch to be named, and that transition is happening as we speak. And finally, maternal and child health funding within Colorado Department of Health also supports some activity in immunization, oral health, nutrition services, and injury and suicide violence prevention programs, as well as Colorado Physical Activity and Nutrition Program. So Colorado received $7.2 million total in Title V funding. $3.24 million goes to state-level activities, so 45%, and 55% goes to local partners and programs out in local communities. The administration of Title V funds has its own logic model so that you can see the activities of the staff who I just highlighted. And this is really around administration, not program. The resources that go into that, as well as the outputs, outcomes, and obviously our goal and our mission statement. So it's just a resource to demonstrate why we do what we do and what our ultimate goal is, and to ensure that we're on track with the work that we're doing on a daily basis. So as I mentioned, in terms of what happens at the state level with Title V staff and funding, we're responsible for submitting an annual block grant application reporting, which is on the website if you'd like to look at it. Every 5 years, states are required to do a state-level needs assessment, and that's also a result of the Government Performance and Results Act. We obviously have to manage the budget. We allocate funds to the state-level programs as well to local health agencies. We oversee data development, compilation, interpretation, and dissemination, and part of that is I was referring to the county data sets that we produce annually and the health status report. One thing I'd like to note is there's currently a survey on our MCH webpage if you go to access the county data sets or the health status report, because we are currently looking at our resource allocation in terms of the data products that we produce, how useful they are, and basically if they're worth the funding that we're putting into it. And so if you use these products, I strongly encourage you to please go on the website, and it pops up as soon as you log on, and complete the survey and let us know how important and useful those data products are for you. We also promote evidence-based programs by distributing information, disseminating information through our generalist consultants, as well as through our website. We offer professional development training and technical assistance both to other state partners as well as to local partners. So, for example, a year and a half ago we had a conference for maternal and child health staff throughout the state that we received some very positive feedback on. We occasionally have, obviously, MCH 101 presentations. We do a lot of one-on-one technical assistance around program planning, development, evaluation, etc. Some of the state-level program areas that we work in are listed here for your reference. Once again, it's a very broad list. And then finally, some of the areas where state-level staff will offer support and guidance, as well as learn from local staff around certain areas, include teen motor vehicle fatality prevention, positive youth development, the Healthy Baby Campaign, immunization registries, and medical home systems buildings, just to highlight some of the areas we tend to focus on. As many of you may know from attending previous presentations that Karen Torello has done, I just was going to do a very, very brief overview of the needs assessment. If you'd like more information on this, please feel free to contact me or Sarah, and we can send you the PowerPoint and handouts from the presentations that have been done on the needs assessment, or it's on the website, so you can go there as well to look for it. Essentially, I was part of the leadership team who designed the process and implemented the process for the needs assessment. As I said, we're required every 5 years by the Maternal and Child Health Bureau to conduct a needs assessment. And this assessment occurred over a year-long period. And the purpose was to identify 7 to 10 specific priorities that could be measurably impacted in 5 years using public health strategies. And we used several conceptual frameworks throughout the process. One is that in defining the different population groups, children, adolescents, women of reproductive age, we integrated children and youth with special health care needs into the children and youth population so that we can also then not only identify priorities that address children and youth with special health care needs as well as the general child and youth population, but we can also develop strategies that are integrated. We also use the life course model, and for those of you who are not familiar with the life course model, in its very essence, and this is the briefest description you'll probably ever hear on the life course model because it's actually fairly complex, but essentially it says that health outcomes are impacted by events that occur over the lifespan, and especially that there are critical periods, such as early childhood, for example, that if you can positively influence the health of a young person, that their health trajectory will be more positively impacted when they're older. So that there's this linkage and this interaction between events and health outcomes throughout the lifespan. Social determinants of health, as many of you are also probably familiar with, takes the view that health is a result of not just health behavior, for example, or genetics, or disease. Rather, it is a very complex interplay of factors such as poverty, education, income level, of course, is related to poverty, built environment, policy, et cetera, et cetera. So it takes a very broad view of health and health outcomes. So the needs assessment process was 3 phases. The first phase was a collection of quantitative and qualitative data to identify potential MCH priorities. And the quantitative piece was the health status report, and our epidemiology planning and evaluation branch compiled this report after many, many hours of research. It is an excellent resource, and I encourage you to go on our website and check it out if you have an opportunity. From a qualitative standpoint, we convened 3 groups of 8 to 12 panel members, both state and local level staff members attended. It was a total of 9 hours of facilitated discussion. The expert panels were organized by population groups. So there was an early childhood group, a group for older children and adolescents, and a group for women of reproductive age. And as I said, the group for early childhood and child and adolescents included children and youth with special health care needs. These panels went through, as I said, a facilitated discussion to determine what those priority issues were within their communities and across the state for the MCH population. Each group of panels came up with, I believe it was 9 to 12 priorities. And so that would have been, between 30 and 36 priorities across all 3 groups. So we needed to take that set of priorities, cross-reference it with the health status report, determine where the overlap was, where the potential gaps were. And then we put all of these possible priorities into a stakeholder survey. This stakeholder survey went out to local health agency staff, as well as some other MCH stakeholders. There was also a capacity survey that went out to local health agency directors. And we asked for people's input on which of the priorities seemed to be the most important and the most compelling for us to address, and also the most feasible from a capacity standpoint. And then phase 3 was the final prioritization process. So this included state staff who had expertise in all of these different priority areas to come and present on why their priority was truly the most necessary for us to address in the new list of priorities, as well as determining what the performance measures were that would accompany these measures. So it was a very involved process, and as I said, I'm giving a fairly brief overview. It was a year-long process, but at the end of the day, I wanted to present you with the priorities. And I'm not going to refer to it in the presentation visually, but there is a table that I sent as a handout that has all the new Colorado maternal and child health priorities for years 2011 to 2015 outlined in the table with accompanying state performance measures and national performance measures. And one thing I would say is that some of the state performance measures may not be the most proximal measures to demonstrate an impact on a specific priority, but they are based on the data that we had available to us, existing data. So if some of them maybe seem a little disconnected, that is why. But certainly the implementation teams organized around these priorities here at the state will design logic models evaluation plans that will include more proximal measures to ensure that we are making an impact over a 5-year period. So I'm not going to read through these. I think you can go ahead and do that on your own, and I'm sure many of you are already familiar with these. So I will move on to local maternal and child health. So I'll start out with saying that out of the $7.2 million, as we said, $3.96 million goes out to local communities. This does not include HCP general fund dollars. This is just Title V dollars. But it does include funds for prenatal, child, adolescent, and children with special health care needs, activities, and efforts. To begin, about 46,000 of that 3.96 million goes to small local health agencies. So these were the former county nursing services. They do receive a very small amount of MCH funds, and now those funds have been rolled into their Office of Planning and Partnership per capita contracts to support infrastructure level activities for those agencies. So to contribute to their public health planning processes, staff time that it takes to basically run their day-to-day operations, because we know they are all serving the maternal and child health population. These small local agencies also have contracts with the Children with Special Health Care Needs Program, or HCP, for care coordination and local systems building. So the rest of the presentation is going to actually refer to the 15 local health agencies, which were formerly the local health departments, and 2 HCP regional offices. And the distinction between the small agencies that I just mentioned and these agencies is that these larger agencies have contracts with the Department of Health for both prenatal, child, adolescent, and children with special health care needs services. They have combined contracts to address all of those areas. So I listed the names of the agencies here. And these agencies, because of their contracts and because they receive significantly more funds, participate in a much more intensive process around planning and reporting. So as we know, local health agencies in Colorado have great variation in their staffing levels. Some of the smaller agencies literally have 1 or 2 staff who are not only working on MCH, but are working on a variety of other programs. And some of our larger departments have, 5 or 6 staff who are only working on MCH. Well, that might be a bit of an exaggeration, but there is a great variation. We look to our local agency partners as leaders in their communities as well as in the field of MCH. As I said throughout, we have a lot to learn from people doing the work on the ground and the lessons that they've learned and the successes that they've experienced. So we look to that leadership and that expertise in the work that we do, and we do try and partner and collaborate when it comes to everything from looking at best practices to determining the best process for administering these funds. And finally, we know that local health agencies are responsible for, local assessment, planning, implementation, evaluation. And I'll take a moment here to say, because I always get this question, which is a very good question, is how will we plan to align the MCH planning process with the Office of Planning and Partnerships and the Public Health Act requirements of doing a public health plan, and an assessment and a plan. And my response is that we are very interested in aligning our efforts, and that we've actually been in conversations. The Office of Planning and Partnerships has a very, very big task to achieve, and so they are doing it in incremental steps. And the more we learn, the more we will kind of, sorry, just spaced, the more we will intentionally work with them to streamline both processes. And one example, actually, I will say is for those agencies who are doing a health assessment currently for OPP and who are going into their MCH planning process this next year, we won't require, the checklist. For those of you who are, seasoned MCH professionals and know all about the MCH planning process and all the tools, I mean, obviously, if you're doing a county level assessment, we're not going to ask you to do a separate assessment on MCH, because MCH is part of your overall population. So that's one very tangible step that we're going to take to, decrease the work and streamline the process for agencies. So just going back to local agencies, the funding levels, just as the staff vary, the funding levels vary. Some of the smaller agencies, such as Broomfield, receive around $38,000 for all those program areas, whereas some of the larger agencies are receiving near $1 million. So from a state level standpoint, it can be challenging to create expectations and program requirements that are kind of fair and consistent when you have agencies that have such variation in capacity and funding. But we do the best we can, and like I said, we try and do that in partnership. So in terms of our relationship between the local and state agencies, the fiscal partnership, that is, essentially the Title V dollars are administered somewhat like a grant program. There's a contractual relationship. Funding's based on a funding formula, and our federal fiscal year is October 1st to September 30th. We now ask agencies to invoice us for services rendered, and we are required to participate in this contract management system, which is basically a contract performance monitoring system where we assign quarterly ratings on the performance of each contract. And finally, we implement monitoring mechanisms because it is a contract, so we're required to ensure that the work is being completed for the monies paid. And these take place in the form of quarterly progress calls, which many of you have already probably participated in with your generalist consultant. And we have received positive feedback from local health agencies as well as from the generalist consultants that this has been a really helpful mechanism to just keep up with what's going on at the local level and what's going on here at the state, and ensuring that if there's any support that's needed, we can provide that. And we know that there's always changes happening on a day-to-day basis, so it's helpful to stay in touch throughout the year and keep up on what's going on. And finally, both fiscal and program staff are involved in kind of all of these functions. From a programmatic level, in terms of our partnership, as I said, we fund these 3 different program areas. We have the MCH Generalist Consultant model that was just developed, once again, as a result of local state partnership and work group discussions. Essentially, this model implies that there's one generalist consultant assigned to each agency who represents all the 3 program areas and can really be a primary contact for the local health agency and can help connect local health agency staff with anyone here at the state they may need to speak with. And once again, this model has been in place for 3 years, going on 3 years now, and it has also been, from what we hear, a successful model. We also have program specialists here at Maternal and Child Health who obviously have expertise in certain topic areas and can provide technical assistance and support to planning efforts at the local level, and also will go to local program staff to ask them what they're doing and determine if they can help support a best practice or share best practices with other groups throughout the state. So with the new priorities, now we're going to kind of go from having program specialists to implementation teams who are groups of program staff here at the department who will be basically developing resources and guidelines around priorities where there is a local role. And there may be some local staff participating on those implementation teams. And also, obviously, we provide consultation, technical assistance, but we hope to have a supportive relationship, two-way communication, and opportunities for collaborative decision-making. So we're heading into the home stretch here, so I think we will be done actually by 11 just to pace ourselves here in terms of the presentation piece, and then we can go into questions. So just to overview the local health agency planning process for those of you who may be new to it, it actually begins the March prior to the fiscal year start, and as we said, that fiscal year begins in October. It happens once every 3 years, so each year a group of 5 agencies or 7 agencies is asked to commit to going through this fairly intensive process to create a 3-year plan. The budgets and some of the other forms, unfortunately, are still annual, so those do need to be submitted each year. But the operational plan, as we refer to the overall plan and scope of work, is every 3 years if there are no major changes from year to year. Also, we ask that, I already went on to the next slide, that staff who are going to be involved in producing the plan, developing the plan, will attend an orientation meeting in March, and this year that's going to be March 7th and 8th, and it actually will happen at the Daniels Fund. I haven't sent that information out yet, but it is going to be in Denver. And at that point, we review guidelines, which includes all of the policies and procedures around the planning process and around contracting with the state, as well as some of the program expectations tied to the dollars. We also disseminate the agency who's going through that 3-year planning process. We disseminate their county-level MCH data as well as trend analysis for a 3-year period. There's also an opportunity for networking. After this initial meeting, the generalist consultants and the local health agencies participate in 2 subsequent meetings. One meeting is focusing on the assessment piece, which is reviewing the MCH checklist, which is an assessment tool basically, assessing possible priorities for the 3-year plan. And then the second meeting really is based on development and whether it's considering different evidence-based programs or strategies, maybe ways to improve your current programs or strategies. It may be to help develop goals, objectives, activities, or maybe it's to help develop evaluation plans. And one really wonderful asset or resource that we've been able to share with local health agencies in the last year is our staff from our epidemiology planning and evaluation branch, who have been now very involved in both the assessment process in terms of providing data, providing some follow-up data, providing interpretation of data, or some assistance around understanding agencies' data, as well as on the evaluation side, we've been assigned an evaluator to work with us. And this, of course, is not free. We have to pay for these services, but and that's one of the reasons, just going back to why we're reassessing the value of the data products, because now we're putting so much funding into supporting technical assistance kind of on the ground level for developing evaluation plans and doing assessment that we're just needing to ensure that the investment of our funds is going in the right direction. So any feedback that any of you have on that, of course, I'm open and happy to consider, and as we move forward with decision making around that. And finally, in terms of the planning process, after the plan is drafted, we ask that a draft plan be submitted June 1 and then a final plan be submitted July 1. And of course, the generalist consultants review the plan, but by this point, there's been so much work collaboratively happening on this. The hope is that the plan that's submitted really is the plan that everybody's already agreed on and invested in, and the approval process is no big hurdle. So, and finally, we contract August, September, so that by October 1, everyone's contracts are in place and you're ready to go. So in terms of expectations from MCH here at the state level for the funds, they differ, somewhat from program area to program area. So prenatal, child, adolescent, we do ask that agencies with the funding allocated to these 3 populations address one of these target populations. Of course, the local health agency determines which population and which priorities they'd like to work on based on needs assessment and the funding available. How this will interplay with the new Colorado priorities is still being determined. For FY12, given it is coming up so fast and our implementation teams here at the state are just getting going, there's a good chance there may not be a huge shift in the way that we ask agencies to prioritize their needs, but that is yet to be determined. So, I mean, there are the realities of a very tight timeline. It is almost the new year. So, but certainly we do hope that there is an opportunity to align the strategic direction at the state level with the direction at the local level so that we can see an impact over 5 years on those outcomes. Also, local health agencies determine the type of strategy that they would like to use based on the priorities identified, the community fit, staff capacity, expertise, and MCH funding levels. And of course, this is in collaboration with their MCH generalist consultant. We do ask that strategies be evidence-based or based on promising practices. And then the local health agency determines the evaluation plan. The other program area is children, youth with special needs. The expectations here are slightly different. The population is identified as all children with special needs, births to 21, and it is asked that agencies implement both care coordination and local systems building services. And of course, they may also coordinate specialty clinics and send their staff to, professional development training and meetings, etc. Within each of these services, care coordination and local systems building, a similar process occurs to the prenatal child adolescent side. So the local health agency would determine the population, or if there's a subset of that population perhaps where they would like to focus, which priorities they want to work on within care coordination, the funding availability, how they're going to go about doing care coordination, and ideally strategies would be evidence-based or based on best practices and include an evaluation plan. And as you all know, who are working in those programs, that there are guidelines around care coordination as well as for specialty clinics, and policies and guidelines that are available on the HCP website. So of course this is all within the realm of those policies and guidelines. So finally, just to share that, of course, the plan is a tool that we hope that agencies can use throughout the year. It is dynamic, and we understand that, and that it changes over time due to, whether it's community events or staff turnover, etc. So we're always working together to ensure that we both know what is happening with local health agency plans and with funds. There is a year-end report on plan implementation, which all of you just submitted, for those of you who work at local agencies. And we also ask for numbers served because we have to report that back to block grant for block grant reporting. So once again, some examples of local programs, and really I've had, since Lynn Bindle, our generalist consultant, retired, I've had the honor really of reviewing some of the local health agency reports, and I can say there's so much great work happening at the local level. It's really impressive, and these examples actually mirror the examples at the state level, and the reason for that is to just show that there already is a partnership and an alignment of the areas that we work on, and it's because both of those areas are really based on assessment and what the issues are facing children, youth, and women in our state. And so, we still grapple with what maybe the best way to address an issue is, or the most effective way to address an issue, but I think the fact that we're aligned on what some of those issues are is exciting and promising. So I am happy to answer your questions, although I'm finished presenting and happy to be finished presenting. So actually I will stop the recording at this point, but I'm not going away.